Greetings, I'm Cliff Rosendale and I'll be presenting at a Skin Cancer Symposium event on March 21 and 22 at the Melbourne Convention and Exhibition Centre. Together with my colleague Simon Clark, we will present dysplastic nevus as the least likely nevus to be associated with a melanoma. This is a paper we co-authored last year. A diagnosis of dysplastic nevus has no clinical relevance and unnecessarily confounds therapeutic decision making. This was the first paper on dysplastic nevus, published in 1980. In this paper, they took lead areas adjacent to a vertical growth phase melanoma that they had originally classified as superficial spreading melanoma. They deliberately reclassified it as a residual element of precursor dysplastic nevus. That's how it all started. And since 1992, the WHO has defined dysplastic nevus on histological features alone. It cannot be diagnosed clinically and dermatoscopically. And in 2017, there was a meta-analysis which showed that there was no significant difference noted regarding the association of nevus-associated melanomas with dysplastic or non-dysplastic nevi. And this was verified by a second meta-analysis. In fact, it showed in the first one that when they excluded congenital nevi, the most common nevus associated with a melanoma was the bland dermal nevus, and the least likely was a dysplastic nevus. What about genomic studies? Well, regardless of whether some histologically diagnosed dysplastic nevi are shown to harbour genetic differences to common nevi, a nevus-associated melanoma is no more likely to be involved with dysplastic than a non-dysplastic nevus. So, a diagnosis of dysplastic nevus has no clinical relevance. And any assertions about melanoma precursor status of so-called dysplastic nevi or melanocytomas are at the most speculative. I like cats, and I like the cat analogy to nevi. There are common nevi and there are common cats. And then there's this dysplastic cat. Now, with respect to nevi, they've been regarded as harmful since 1980. In fact, a dysplastic nevus is just a nevus, like a dysplastic cat is just a cat. Cats don't turn into tigers, and nevi don't turn into melanomas. There is no proof that they do, and just because there is a nevus associated with a melanoma doesn't prove precursor status. We know that little tigers turn into big tigers. And we also know that morphologically, little melanomas become big melanomas, and you can see this gradual transition whenever you have a melanoma on the face and access to selfies. We will introduce you to a new way of classifying melanocytic lesions, the BMI, or benign malignant indeterminate method. A benign melanocytic lesion is a nevus. A malignant one is a melanoma. And then there are some where the pathologist cannot differentiate between the two. And that's because of the limitations of dermatopathology, not because a nevus is trying to turn to melanoma. And these are correctly and accurately classified as indeterminate lesions, not intermediate, not borderline, but indeterminate, just recognizing the fact that the decision cannot be made. And that's an honest, accurate way of reporting. As you know, with the method of common nevus, dysplastic nevus, and melanoma, most nevi that you excise will be reported as dysplastic. However, with the BMI method, it turns out that a minority are classified as indeterminate, and most are benign or malignant. So I actually measured that in my own practice for a period before I negotiated with my pathologist the BMI reporting method. The number of indeterminate lesions was half that of the previously classified dysplastic nevi. We look forward to seeing you there on March 21 and 22 at the Melbourne Convention and Exhibition Centre. Thank you.